Good morning, everybody. I'm sorry that my plane was late, so I had to give this talk after Nordic, but then I had the pleasure to listen to him, and I can confirm much about what he was telling you. I've been working with ALS patients as neurologist at Haukeland University Hospital for 20 years. And I've together with Professor Ole-Bjørn been running the ALS clinic there. I have been interested in ALS since mid-80s. And I've been given a very broad topic today to talk about ALS research. ALS research is very much, and I can't cover it all, as you will all understand. But I hope I can discuss some important aspects of the ALS research with you. But before I do that, I will discuss with you what ALS is viewed from a neurologist. Warbeck said that ALS patients are very heterogeneous. Not one single person is exactly the same as another one, and he is very much right in that. He also discussed with you the problems with setting the ALS diagnosis. Some people want to have an early diagnosis, some people do not that. And this is the field that we neurologists have to work in. All the patients are different. So I will now just shortly walk you through the clinical characteristics of ALS, the pathological findings, and some genetic aspects of ALS, which is important when we are in front of the ALS patient. First, the clinical characteristics, and as you know, ALS are grossly grouped into two main groups of patients. It's the bulbar onset, which is loss of speech or speech problems, and which can also be followed by swallowing problems as initial symptoms of ALS. And the other one is the classic ALS, or the spinal form of ALS, which starts with a paresis in a hand or a foot and then spreads from there. Frequently in the sporadic ALS, fasciculations is present, and fasciculations, that is the muscle movements, small muscle movements all over the body. And but this is less frequently seen in the bulbar cases. ALS is slightly more frequent in men than in women, and we consider today that the annual incidence, which means how many new cases there is in a certain population per year, is around 2 per 100,000, which means that we in Norway would have 90 new cases per year. And I do not agree with Warbeck that this has been poorly studied. This has been very well studied, especially in Norway, and we are quite sure about the incidence. But then when a patient comes to the neurologist and he has a weakness in a hand, or he has some dysarthria, that means speech problems, then it can be difficult to set the diagnosis. And actually we have very few positive ways to put an ALS diagnosis. The most important examination to perform, except the clinical examination, is the EMG. And why is it so? You know, EMG, that is putting needles in the muscles in the body, and to see what signal you get from the muscle when you do a muscle contraction. And in ALS, it will be that you have defined EMG signals from the muscles where there is a palsy. But that will not be enough for an ALS diagnosis. ALS is a generalized disease. It should be present in almost all muscles of the body. And that's why EMG is important, because we will also see changes in muscles where there is no apparent palsies, where there is no paresis, and where the patient feels completely well. So if we see that the disease is generalized, then we think that this might be ALS. Nowadays, ALS is different, as Warbeck said. It is that ALS is a disease that affects the motor neuron, that is the cell in the brain that gives muscle contraction, and this cell goes to the cell in the spinal cord that goes to the muscle itself. And if it's a main affection of the cell in the brain, then we would have what we call a spastic disease. Then there is no atrophy of the muscles don't disappear, but the patient loses power and he is spastic. Probably you know what that is. And in the other way around, if it's mainly affection of the motor neuron in the spinal cord, then there will be muscle atrophy, the muscle disappears. So the patients are very different. And in this aspect, we have to consider differential diagnosis, and I've noted the most important differential diagnosis in ALS here. And perhaps the most important one is, like we see in this X-ray here, the MR of the spine with narrowness of the cervical spine, which may lead to paresis of the arms with atrophy and spastic paresis of the legs. And especially in elderly, this is quite common, a common differential diagnosis. But then we also have other conditions, especially what we call neuropathies, which may mimic ALS and where the diagnosis can be very difficult. But ALS is a progressive and serious disease, and usually it progresses, and there is a mean survival after diagnosis of only 2 years. So after 2 years, half of the patients will have died in the normal progression of ALS. But as you see from this curve, which is from some early work we did in Haukeland or in Bergen, then we see that there are some 10% that are long survivors. And this was before we had the respiratory assistance. So this indicates that there is a portion of ALS patients that live long, and it's very important for me when I'm in front of the ALS patient the first time, first to tell him that I might be wrong with the diagnosis. I might be wrong, because it's a difficult diagnosis early in the disease. And then second, if I am right, there is still hope that the patient will be a long survivor with this disease. And I've seen that several times, that ALS kind of burns out so that it stops to develop, and the patient will have many years where he still can function with the disease. And this is important information for the patient. But with the time, the disease will progress and it will involve all muscles, and that makes, then comes the respiratory problems, and all muscles are involved except for eye muscles that are accepted very late in the disease, and which of course, as all will know here, is used in the communication with ALS patients in the late stages of the disease. There is an issue as well which is important to talk about, especially when I talk about ALS research, that is the mental symptoms in ALS. Usually we say to patients that ALS is a pure motor disease, which gives paresis of arms, legs, muscles in the mouth, etc. But there is no mental symptoms. But this is not quite true, as I will come back to. Usually there might be some mental symptoms during the course of the disease. So what happens in the body when these neurons die? Well, what we see, and this is consistent in all ALS patients, even if we have this heterogeneous spread clinically, what is found in the pathologic study of the ALS is that there is a loss of motor neurons in the spinal cord, and there is a loss of motor neurons in the brain, which causes what is called diffuse sclerosis of the spinal cord. And this gives the paresis and the spastic appearance of the ALS patient. What is important for ALS patients is to know whether this is an inherited disease or not. Most isn't important because of the children, of course, as you will understand. And if you go to the internet, you will see that some 10% of ALS patients are inherited. And patients may then think that this means that there is a 10% risk that my disease is inherited. But this is not the case, because ALS, when inherited, almost always is inherited in what we call an autosomal dominant way. And autosomal dominant inheritance means that ALS is present in every generation, and that 50% of the children will have the disease. So the ALS families, they are identified and they are known. And if there is no ALS in the family, then we can be 100% sure that it is not an inherited disease. And that is important information for the family, as you will understand. An important breakthrough in the ALS work came some 10 or 15 years ago, when it was discovered that there were some mutations in the SOD gene, which is called superoxide dismutase, and which I will come back to in my talk on the research, that there was a mutation in this SOD gene in 20% of the inherited cases of ALS. So we know the genetic defects in 20% of the patients. And mutations other than SOD are very rare in ALS. So for all clinical purposes, ALS, if inherited, is autosomal dominant, which means that it is in every generation. And in some 20% of these inherited cases, there will be a mutation in SOD. So, on this background, where do we stand in the ALS research? And I will try to go through these items with you to look at the epidemiology, which is how ALS is spread around, how frequent is it in men and women, and are the differences in different parts of the world, etc. I will look at the genetic research that is done, and that is in inherited ALS. And then I will look at disease-modifying treatment in ALS, which I assume will be of interest for many of you. This is work that is mostly done in ALS models, which I will explain, but it's also done in the patient and then as treatment trials. Stem cell treatments is something that patients and carers usually are very much occupied, interested in. And finally, I will talk about ALS management. Of course, ALS management is a topic of its own. It could be and I see outside the door, that ALS management, of course, is the main issue here. But I will just put a few highlights on some research that is being done on ALS management. So, first about the epidemiologic research. And then there is the question that has been posed during the last 20 years, whether there is an increase in ALS, and whether this increase is contributed to environmental factors, which perhaps we should discover and then be able to control. And there has been some publications lately of increased risk in patients or in soldiers from the First Gulf War, and especially in professional football players. I will discuss this with you. And then I will talk about some symptoms from the mental system in ALS. First, what we did in Norway in the 90s, that was to see that, or to do a retrospective study on the occurrence of ALS in Norway. And this was done from the death registry system in Norway, which is a very well-functioning system. And we are quite confident that ALS is such an important diagnosis that it will be mentioned, it will be registered on the death certificates. And if we look at the death certificates in Norway, we see that from the 60s and to the 90s, we have a considerable increase in numbers of ALS patients. And you see an incidence, annual incidence here, above 2 per 100,000 per year. 2.5 actually. So this could of course be due to the fact that the medical service is better during this period of the time. Or it could be due to more consciousness about ALS as diagnosis among doctors. That is a possibility. But it is also a possibility that this increase purely reflects that Norwegians now live longer than they did in the 60s. And especially the women live longer. So if we look at the age group where ALS occurs, we see this lower curve here is from the 60s, then the 70s, 80s and the 90s, and here we have the age groups. So what we will see is that the incidence was similar in age groups up to 60 years. But above 60 years, there was a considerable increase in the 80s or 90s. So this tells me that most of the increase that has been observed in Norway probably reflect that Norwegians are getting older, and simply by living longer, there is an increased risk that ALS in the population will increase. And this has quite recently been confirmed from other countries. This is from a recent publication from Ireland, And they have studied, like we did in the 90s, the incidence of ALS there, and they have now recently done it again. And they say that there is a stable incidence of ALS in Ireland during the last 7 years, and that the annual incidence is 2.5 per 100,000 per year, which is similar to what we found in Norway in the 90s. So probably we can today be quite sure that the incidence actually is quite stable. We don't have to fear that there really is an increase in the number of cases of ALS. And as in Norway, they found that ALS is slightly more frequent in men than in women. And what is interesting with ALS is that although being a neurodegenerative disease, which means that the neurons start to die without any known cause, in ALS there is a fall in incidence in the highest age group. And that we also found in Norway, as you saw from the last curve here. There is a decreasing incidence in people above age of 80. And the reason why there is a decrease in this oldest age group, we actually don't know. Of course, it can be that this is people that already are in nursing homes and that they don't get the diagnosis. About environmental factors, we published a paper some few years ago which looked at the differences between ALS occurrence in women and in men during the 10 years periods mentioned here. And what you will see is that there is an increase in both groups, but especially that women seems to approach men. And when we see this kind of curves, we immediately get suspicious that there might be an environmental factor that is going on. And the reason why we think that is the history of smoking, because smoking and lung cancer was long thought to be unrelated. But then they realized that this was something that occurred only in men, and it was men that smoked. And the relationship between smoking and lung cancer was defined. What we see now, of course, is that women get lung cancer as frequent as men, and lung cancer is certainly an environmental disease. It's certainly caused by smoking, and this kind of changes should put our suspicion that ALS that there may be an environmental cause of the disease, that at least partially is involved in the risk of developing the disease. And on this basis, some publications have been coming up during the last few years. And this is ALS among Italian professional football players. And the first publication came 2 years ago. And they had shown that there was observed 5 cases of ALS in professional football players in Italy, and the risk, or the expected numbers, should be less than half, or only 0.5. So the risk was substantially increased that professional football players should get ALS. So there was a lot of speculation coming out of this. This was, of course, whether Italian professional football players use drugs like doping or whatever. But it was also considered that it could have been something with what they used to make the grass grow in the Italian football fields. Whether this could be a risk factor of developing ALS. And what they also found was that especially it was a midfield player that was on risk. And as you know from football, midfield players are the people running most. So there was also a discussion whether ALS was at increased risk in people that train much, that train hard. And this hard training theory about the risk of ALS was also enforced by the data from the veterans from the first Gulf War. In these veterans, they also found an increased risk of ALS, but of course, these people that was in Iraq in the early 90s also were exposed to all kinds of toxins during that war, and it could be that it was more like a toxic effect. But the increased physical effort theory and the toxic theory when it comes to ALS etiology is very much discussed today. And after these reports from Italian football players, there have been several reports on football players that has gone ALS. And this year, there was a publication from England which showed 3 soccer-playing friends that developed ALS. And these were not professional football players, but they played a lot of football. So they could have ALS because of the physical theory, but not of the toxic theory, because these football players there, they had never been taking any drugs to increase their performances. So the discussion is still going on, but there was a recent review here, published only a month or 2 ago, where Armand, which is American, he went through all the reports from all the football players, and he concluded that it was very unlikely that these football players had ALS due to their disease. He confined most of the dating to statistical coincidences, and that either sport or toxin in these players could really play a risk factor in developing ALS. Then it comes to cognitive functions and ALS. And during the last 5 years, there has been published a lot of data on this issue. And I will only point on a recent paper from Neurology, which is an important journal, and who has studied mental function in ALS patients. And they had then used tests that were independent of motor performance, of course. And what they found, and what has also been found previously, is that around 50% of patients, they might have some cognitive defects. But the cognitive defects in ALS is not like decreased memory or decreased ability to concentrate and things like that. It is different from ordinary mental dysfunction, as we usually think when we speak about decreased cognitive functions. But it has been shown that it is small personality changes that may occur during the development of the disease, and this might be important for us to know about, me as neurologist and you as carer, because there might be situations when we have to take decisions for the ALS patients. I don't say that we should do that frequently, but there can be situations where that is necessary. In 15% of the ALS patients, they fulfill the criteria for what we call frontotemporal dementia, which is language problems, memory problems, and personality changes. So there is an issue that goes on cognitive function in ALS, and this is an important issue both for me as neurologist and for all carers, and which has to be discussed further, but we don't know all about this now. It has just been coming up during the last few years. Then we come to the genetic research. And when we come to genetic research, as I mentioned for you, some 10 years ago, was localized the first mutation that was related to familial ALS, and this is the SOD gene. And I will now discuss this, which is the mutations and how this impact on the individual patient, and if there is any correlation between genetic ALS and dementia. And this is just to illustrate the SOD, the superoxide dismutase gene. And what is SOD? Well, SOD, that is an enzyme that takes away toxic substances. And what do you think about toxic substances? Is that something that we eat? No, it's not that what I mean. When we produce energy, when the cells produce energy, which is ATP, then there is production of what we call free radicals. And free radicals, that is very reactive substances, which may react with proteins in the cells and disrupt actually proteins. And these free radicals has to be taken care of immediately when they are produced. And SOD is one of such systems that takes care of free radicals that are produced during our production of ATP. So what happens when we have one of more than 100 mutations which has been identified in SOD is that the molecule is destabilized, and especially that there is a loss of zinc molecules in the SOD. And when zinc is low, it destabilizes the molecule, like illustrated here, and when it is stabilized, it finally aggregates. And when the molecule aggregates, it can't anymore be degraded, so it will accumulate within the cell. And when it accumulates, the neuron is in trouble and it will die. So this is what we think happens in the cases where there is inherited ALS and where there is a mutation in SOD. But we must remember that in 80% of the inherited cases of ALS, there is not an SOD mutation. So how does this mutation, is it so that mutations really has any impact on the clinical evaluation of ALS? And the answer is yes. This is from Peter Andersson's work. Peter Andersson has been doing a lot of work on ALS. He works in Umeå in Sweden. And this is from one of his publications where he went through some of the various SOD mutations indicated here in his ALS patients. And what is the conclusion from this slide? From this slide is that there is a considerable variation in, for instance, survival time in patients with various SOD mutations. And best illustrated it is when we look at survival time here, which is 0.9 years in this mutation, which is the most frequent one in North America. And when we compare with the 14 years survival in this mutation, which is common in Northern Sweden and in Finland. So there is then a variation in survival from 0.9 years to 14 years. So there is no doubt that the different mutations in the SOD gene has a significant impact on the evolution of ALS in the individual patient. But this is from a family in Norway, and this is from one single family. The family does not have an SOD mutation, but it is sure that it is familial ALS. And what we see here is that there was a father who had ALS here, who died after the Second World War, and the family had 5 children, of whom 3 got ALS. And one patient had bulbar ALS with short survival, only 2 years, and 2 of the patients had spinal ALS. One of them survived more than 10 years. So this is the same family. One of the sisters lived for 10 years, and the brother lived only for 2 years. So it is not only a question of the single mutation that leads to ALS when it comes to survival. And this makes genetic testing in ALS very difficult, because you cannot use the test to be sure about how the future will be for the patient. What you also can see in this family is that there is a brother here who had frontotemporal dementia. He did not have ALS, but he had frontotemporal dementia. And this is to stress that there in some families is coexistence between ALS, the neuromuscular disease, and frontotemporal dementia, which is the disease with the cognitive decline. And this has frequently been published in Neurology, which has studied familiar cases of ALS and familiar cases of frontotemporal dementia. And frontotemporal dementia is characterized of atrophy of a part of the brain, which you see here is the normal part of the brain, and on one of the side there is loss of brain mass, which is what we call atrophy. And they found that in this family, where some cases had frontotemporal dementia and some cases had ALS, they found mutation in a molecule called progranulin, which is a structural protein for neurons. But I don't think this is the whole truth. This is only from one family, and there is a lot of research going on to find what the crosslink is between frontotemporal dementia and ALS. So then we come to disease-modifying treatment. And here my first word is animal models, and then I have to explain for you what I mean with that. And animal models in research is to take a gene from a human, in this case the SOD gene, the mutated SOD gene, which gives ALS, and implant this gene in a mouse. So then we have a transgenic animal, the transgenic mouse. It looks like a mouse, its whole genome is the mouse genome, except the SOD gene, which is the human SOD gene, and which is the pathologic gene. This mouse, when it grows up, it is normal, but when it comes to some 90 days or around that, it gets sick. It gets paresis in its hind legs, and it gets pulses in his forelegs, so that within 10 or 15 days after onset of this paresis, the mouse will die. And if we study this mouse pathologically, it has signs that is very much similar to what we find in ALS in humans. But this is a model. This is an ALS. It's a genetic ALS model. It's not human ALS. We must be clear on that. It is a model. It's not ALS. So, but we will go. I will take you through this model and what we have in research there, and I will also discuss with you what kind of research we have on treatment in patients. So this is from this mouse model. What you see here, that these mice, they live until age of approximately 200 days, and then they have the disease, which lasts for about, let's say, 20 days. There is a mean survival of only 10-15 days, and after 20-40 days, almost all the mice are dead. If these mice are given antioxidant therapy, and here are two experimental drugs, and antioxidant therapy is wise to give. As I told you, SOD is an antioxidant system, and there is something wrong with it in ALS patients, we think. And if we give this antioxidant treatment, we see that the mice seem to live longer. So there could be some indication that this drug could make humans live longer. And there are other subsets of studies in the same way. This is COX-2 inhibition, and that is interesting because we do have COX-2 inhibitors in humans, which is Vioxx and Celebra, which are used for rheumatoid arthritis, but has increased risk of cardiac disease. So we don't use them much in human medicine. But if we give such a COX-2 inhibitor to ALS mice models, then we see first up here that there is a prolonged disease onset. We see here that the mice usually get the disease after 100 days or so, and then there is a disease evaluation here, and within 30 days from onset, the mice will be dead. But if we give them the COX-2 inhibitors from day 90, we see that the mouse only detects the disease after 130, 150 days. So there seems to be a delay of onset of the disease. This is not very interesting in sporadic ALS, because who will know that he gets ALS? Nobody, of course. But this is this kind of treatment. Here, they give COX-2 inhibition after onset of symptoms at 100 days. And what we see is that if this is given at onset, this is the treated group, and this is the untreated group. And what we see is that the untreated group will die earlier. So it seems that COX-2 inhibition could delay the progression of ALS in these mice. I spoke to you about the zinc molecule. It seems like the zinc molecule is moved away from SOD in the inherited cases. And this is what occurs if we give zinc in the diet to mice that are transgenic and who have the mutated SOD. We don't see a big effect. We see that the survival time in control mice will be 130 days, and it will be 137 days in the zinc-treated mice. So we don't see actually any large effect. This is a new kind of experiment which has been set up lately, where we do genetic modeling of the animals. First, we have the SOD mice, which is, as I explained to you, mice that have the human mutated SOD in their gene. And these mice, they also have another genetic manipulation. Genes that are involved in oxidation, which is the toxic process that I mentioned, are taken away by so-called knockout technique. It's called, they knock out the gene, so they call it knockout mice. And what we see here is that if NOX2 is taken out in these mice, they live considerably longer. This is the survival in the control mice, which get diseased at around 100 days and which are dead within some 40 days here. But then we see that the NOX2 knockout mice, they will have onset of disease much later than the control mice. And also the evolution of the disease seems slower, as we see here. But there is always a but. These mice that had the NOX2 knockout, they had a lethal eye infection in several cases, and although they were treated intensively with antibiotics, this infection was so severe that several of the mice died. So it's obvious that NOX2 can't just be taken out in a cell. If we take that gene out, we will have lots of other problems than just concerned with the SOD gene. So when I say this, why don't I show any data from humans? Well, this is because in humans, some of these treatments have been tried in humans, like for instance, COX-2 inhibition. But all studies have failed before it has come to any positive results. So these data, neither COX-2 inhibition or antioxidative therapy with vitamins, which has been given to ALS patients, have shown positive results. So although we can see changes or effect of treatment in mice, we can't find that effect on treatment in humans. And why is it so? The most probable reason is that human ALS is very different from the models. So most of all, human ALS is, for most treatment cases, sporadic disease. It's not an SOD disease. So it's most probably that the disease is very different in humans and models. So models are useful, but they do not give us the answer. So what about stem cells? I've put a provocative word here, which is charlatans, but it was used on the EFNS, and that's why I use it as well. So the question is if this is anything to go, if ALS patient will do almost everything to try to find out the cure for their disease, and that is easy to understand, and I help them to try to get there. But there must be a limit somewhere. And this is from stem cell research, which is very recent research, of course, and this is from a paper which is just some few months ago, where they implanted human stem cells in the brain or in the spinal fluid of mice, SOD mice. So this is experimental studies. And what they see is that there is increased number of neurons in these mice who had implanted the stem cells. So it seems that the stem cells, which produce a growth factor, makes the motor neurons live longer. Here are the control cells. But disappointingly, there was absolutely no effect on survival time. You see here in red the mice that had the stem cells implanted, and you see in blood in blue the mice that did not have stem cells implanted, and the survival time was exactly the same in the two mice. So in this mouse model, no effect of stem cells. So stem cells that was implanted into SOD mice, and this is another kind of stem cells which were not generated to produce growth factors, but was stem cells that could differentiate to all kinds of neural cells. And when implanted into the spinal fluid through the cisterna magna in the brain of these animals, there was absolutely no effect on survival, what you see here. So the stem cells in the animal models do not seem to have any effect. But nevertheless, there has been run research to try this out in humans. And this is effect of anti-apoptotic treatment in ALS patients. And it is so that in ALS, the neuron cells, they die from what we call apoptosis. And what is that? Well, apoptosis, that a cell which has come to the end of its life just disappears. Like on the skin, there is a continuous turnover of cells, and the cells, they disappear when they have, done their function. But neural cells, they don't die. They shall rest for all our lives. But the cells, when they die in ALS, it is through what we call an apoptotic mechanism, which is that they die, they just disappear, like they had done their life functioning, if we should call it that. And if we give this treatment to ALS patients and look at the endpoint, which is survival, it's time to death or it's time to tracheostomy, as you see here, and we can absolutely find no difference between the two groups. So also studies in humans are negative. And recently was published this review which summarizes all which has been done on stem cells in a human, and they conclude that there is no effect of any stem cell therapy today. And they also highlight that there are important side effects. Actually, the stem cell therapy is dangerous. There are serious adverse effects, even lethal. So some patients that will die during their stem cell treatment, and most frequent adverse effects were serious brain infections and serious allergic reactions, because these are cells that do not come from the patient themselves. It's cells that come from other persons, and there is an obvious risk of allergic reaction. So the conclusion today, and which was highlighted at the last meeting of the European Federation of Neurological Societies in Brussels in August this year, was that this is being run by charlatans. Today is given stem cell therapy in Russia and in China. The price for the stem cell therapy is $50,000 per treatment, and they claim that there is a 6-month increased survival, but they have never been publishing anything on efficacy. They have never actually showed that there is a 6-month increase in survival. And the conclusion therefore today is that currently stem cell therapy is run by charlatans. So finally, I've come to the ALS management, what research is being done there, and I can't come from Bergen without mentioning that we are doing something on this in Bergen as well. And this is a publication which will appear later this year in the European Journal of Neurology, where we took 14 patients with ALS and drooling. You will know what drooling is. Drooling, that is a running of saliva through the mouth, and which occurs in late-stage ALS patients, especially in bulbar ALS. And this drooling, when the saliva is running, is of course very embarrassing for the patient, and we don't have very good treatment options. So what we did in Bergen was to establish a radiotherapy for these patients, and that is to give them irradiation of the salivary glands. And this irradiation is given as a one-dose fraction, so it's only one treatment, and then it's done. And these patients who had a mean salivary secretion before treatment of 0.5 ml per minute was reduced by some 60% after 1 week, 50% after 2 weeks, and after 3 months there was some 20% reduction in the salivary secretion. And this was the patients, they had a good impression of this. All patients had the impression that before radiotherapy they had too much drooling. After therapy it was suitable in 5 of the patients, and they had a good reduction in some of the patients. Only 1 patient felt that they had no effect. So when the patient have a lot of drooling, this is a therapy option. As some of you will know, Botox injection is also an option. And we do that as well, but we don't have scientific data on that. But my impression is that this effect is better. And then a final point, which concerns a lot of ALS patients, that is, how can I do training? Especially early after the diagnosis, this is an important issue for the patient. Can I do some training with my ALS, or do I then get faster worse with my disease? And usually we have said to patients that they shall be careful with training. Perhaps they should spare the muscles a bit, not use too much muscle effort during their daily workout. And this was some experiments that was done in 2004 where they did training in mice. This is the transgenic SOD mice. And what they saw, that mice that were allowed to run came in this group, and the control mice were in this group. And they didn't find any actual difference, but they couldn't find that training was dangerous for the mice. So there was no increased risk of progression of the disease. And this year, just a few months ago, this article was published in Neurology, and I've only shown up here how this was randomized. There were 2 groups there. Either the patients were taken to training, or they were taken to ordinary stretching physiotherapy. And they could actually show that the patients who had careful training had a better ALS functional rating score than the patients who had no training. So perhaps we shouldn't be so afraid to recommend some careful training in ALS patients now. These data are quite new, and I haven't taken them into our clinic yet, but this is things that we should consider. So with this I've come to my conclusions, and that of course very much ALS research is performed. Also some research is performed in Norway, but no genetic research is performed in Norway. There has been no breakthrough on treatment, but treatment trials are going on continuously in animals, and also in humans in some cases. And there is extensive research is going on the basic pathology in ALS, on what is the mechanism of the development of the disease. And if we have a breakthrough here, I think this will open up new possibilities. So I think there is much research in ALS which is important, not only the genetic, very high-tech research, but also research that is being done in the management of the disease to see what we can do to make the life of the ALS patients as good as possible. Thank you.